My name's Eric Schryver. I'm one of the newest orthopedic surgeons at Boulder Center for Ortho. I primarily focus in sports medicine, but I take care of a whole host of problems. So I have no problem if you have some sort of ache or pain and want to be seen by somebody, come on over. We'll figure out. If I can't take care of it, I'll help you figure out who can. So the topic that we're going to go over today is tennis elbow versus golfer's elbow. We're going to see what the difference is and talk about how we treat it. So again, the conditions we're going to discuss, tennis elbow, which is also known as lateral epicondylitis, and then we will also discuss golfer's elbow, which is known as medial epicondylitis. So we're just going to talk about a little bit of basics about the elbow. So the elbow, it acts as a fulcrum for both your forearm and your hand positioning. You use it in weight bearing for things like mobilization if you need crutches or a walker. And it's also used for weight bearing in overhead sports, whether that's gymnastics or baseball or some sort of overhead powerlifting. It can be used for weight bearing for that as well. And then traditionally, we think about the elbow as a transfer of energy from the shoulder through the elbow down to the forearm and wrist for throwing. And it's also essential for activities of daily living, whether that's eating, brushing your hair, brushing your teeth. The elbow is really important for those activities of daily living. So in a perfect world, someone's elbow range of motion, we're going to kind of talk about what that looks like. So ideally, your elbow range of motion will go from 0 degrees, which would be perfectly straight, to 150 degrees of flexion. So all the way flexed would be about 150 degrees. And that's sort of the maximum motion that we expect from people in terms of flexion extension. Then we also talk about pronation and supination. So if you have your hand at neutral, like in that picture there, and you rotate your palm towards the sky, that would be supination. The way that I always learned about remembering that is when you supinate, you put your hand in a position that you could hold soup. Then pronation would be the other way, palm down. And so ideally, you could have somewhere between 75 to 90 degrees of both supination and pronation. Now, we talk about in the world of orthopedics is what your quote unquote functional range of motion would be. So what is the range of motion that you need to sustain to be able to have function, to be able to complete those daily activities of daily living, like brushing your hair, brushing your teeth. And so that would be flexion from 30 degrees. So just a little shy of full extension to 130 degrees of flexion, as opposed to that 0 to 150 we talked about. And then in terms of your pronation and supination, you only really need 50 degrees of both of those rather than the 75 to 90 in order to kind of have a functional range of motion. So now we'll kind of shift and we'll talk about elbow pain. So it's one of the more common diagnoses we've seen. It's really common among active individuals, and it can be really impactful to your daily activities, whether that's sport or just taking care of yourself and living your life, doing your job. So it's really important for us to get an accurate diagnosis because that can kind of direct us how we're going to treat this and ultimately how are you going to recover from the elbow pain that you're having. So we'll jump right into tennis elbow. Tennis elbow is also known as lateral epicondylitis, which is a fancy way of saying that you have inflammation of the tendons on the outer part of your elbow. And when I say outer part, I mean the outer part. And so something we really need to talk about is what is a tendon? Because if you have inflammation or swelling or irritation of the tendons, what is a tendon? So tendons are the structure that connect muscles to bones. And we have some pictures a little bit later on that kind of demonstrate that. But that's what a tendon is. It helps connect your muscle to the bone, and that helps your bones move and ultimately helps you function. When you have overuse or repetitive use of these tendons, that can cause what we call a micro trauma, and that can cause this irritation, the inflammation of the tendons. So lateral epicondylitis or tennis elbow is simply irritation of those tendons on the outside of the elbow. There's a couple different causes that we commonly see. That would be overuse of your forearm and wrist extensor muscles. So the extensor muscles that help you extend your wrist, those attach right on the lateral epicondyle of the humerus, and we'll show a picture of what that looks like too. Common activities, tennis, hence the name tennis elbow. Really, it's a backhand swing that kind of gets those going. Things like painting, plumbing, carpentry, those sort of activities can, if you do those frequently, lead to tennis elbow. Symptoms of tennis elbow would include pain and tenderness to the outside of the elbow, the lateral epicondyle, pain that worsens with gripping, lifting, twisting motions, like if you're trying to open a door, open a jar. And then you may sometimes get pain that radiates down the forearm towards the hand. Now we do kind of the reverse of that. So golfer's elbow is sort of the flip side. Whereas before we had lateral epicondylitis, we have medial epicondylitis for golfer's elbow. So in that case, it's inflammation of the tendons on the inner part of the elbow, the inside. So causes of this would be overuse of the forearm and wrist flexor muscles. So is where golfer or tennis elbow was inflammation and irritation of the extensors, medial epicondylitis or golfer's elbow, irritation of the flexors. So common activities would be golfing or throwing sports because you're really sort of engaging those flexor muscles when you do those activities. Symptoms of golfer's elbow, you have pain, tenderness over the inner elbow, the medial epicondyle right here. You get some elbow stiffness. We see this a lot in the morning. Generally, this seems to be because patients either sleep in a position or kind of lay on their arm in a funny way throughout the night. So when they wake up, their elbow is just really stiff. And as they work throughout the day, the pain seems to improve and the stiffness seems to improve. And this is also pain, like we said, increases with wrist flexion and gripping activities. So now we're going to kind of talk about what the anatomy looks like. We've used these terms medial epicondyle, lateral epicondyle. What does that actually look like when we're looking at the elbow? So this is an elbow x-ray. The bone at the top is the humerus. Over here is the radius. That's the bone on of the forearm on the thumb side of your forearm. This is your ulna, which is the forearm bone on the pinky side of your forearm. The medial epicondyle, which is that bony prominence you feel on the inside of your elbow, and the lateral epicondyle, which is the bony prominence you feel on the outside of your elbow. So when they talk about epicondylitis, that's inflammation of the tendons right here at these epicondyles where those tendons insert. And you may kind of think, well, if the forearm flexors, why are they causing problems at my elbow? But like we kind of mentioned, the forearm flexors and the wrist flexors, they insert all the way up past your elbow at these epicondyles. Here we can see kind of a schematic of the muscle insertion. And again, here's the pink is the muscle bellies. These are all the extensors. So that's the lateral elbow, which would be tennis elbow. The white that you see here, that's the insertion of that's the tendons as they transition from muscle to tendon to inserting there on the lateral epicondyle. So you can see you have several different extensor muscles that attach right there. And all of those can really kind of irritate the elbow and cause inflammation. Then on the flip side, now we're looking at the medial epicondyle, the medial elbow. Again, there's several flexor muscles of the forearm and wrist that insert there right on this medial epicondyle. Irritation of one or any of those can really cause that forearm or cause the elbow to be uncomfortable. And again, when we talk about epicondylitis, we're talking about the inflammation, irritation, and even just something simple as overuse, repetitive use, the micro trauma that can cause inflammation or irritation of these tendons and can be really, really painful. So some common risk factors for these two conditions. We have age. This most commonly occurs in ages between 30 and 50. Frankly, it often happens more commonly in males as well. Occupation, so jobs that involve repetitive arm movements or heavy lifting, like we had said before, plumbing, carpentry, people that are actively using their hands for their job or for recreation. And then sports activity, repetitive use, overhead athletes, golf, tennis, those can cause these as well. Then specific risk factors for tennis elbow, again, racket sports, that backhand swing is really what engages those extensors, right, that insert on the lateral epicondyle. So a backhand racket sports, that can really irritate those. Frankly, poor technique. Nobody ever wants to be told that their technique is poor, but if you have poor technique, that can strain the muscles and the tendons in an inappropriate way, and that can cause extra strain on the tendons and therefore cause the inflammation and irritation. If you use the inappropriate equipment, if it's not the appropriate size for you or it causes you to have poor technique, it's always nice to blame the equipment for your poor technique. But if you have inappropriate equipment, that can cause the discomfort as well. Golfer's elbow, sort of the exact opposite, only with golf. Poor golf mechanics. If you throw a lot, baseball players or other sports where you're throwing a lot, you can get that pain because you're engaging the flexors. Again, when you throw the ball, you're engaging those flexors that insert on the medial epicondyle. And then if you have poor lifting techniques, but none of us have those, so nothing to worry about there. Some of the things that we do for our clinical exam to see, okay, you tell us where you're having the pain, but these sort of special tests can help us pinpoint even further what's the diagnosis so then we can dictate how we treat you. So a couple of special tests that we do for tennis elbow. The Cozen's test, that's a resisted extension. So you'll hold your wrist in extension. I try and force your wrist towards flexion. That you're really firing your extensors, and that can be really painful right over those tendons. Cozen's test, or I'm sorry, Mills test, your elbow is passively extended while you hold your wrist flexed. So again, that just stretches those extensor tendons that insert on the lateral epicondyle and can cause a lot of discomfort. Golfer's elbow, the reverse Cozen's test. In this case, you hold your wrist flexed. I try and extend your wrist, and simply you trying to resist my force to extend you really engages those flexor muscles and can cause a lot of irritation and inflammation and make you want to let go. Generally, for our diagnostic imaging, we always like to get x-rays. So even if you come in and we're pretty sure you have a soft tissue injury, we got to get x-rays. It's a great place to start. You can rule out fracture, you can rule out arthritis. It's just really great information. You can learn a lot about soft tissue from x-rays as well, but we got to start there. It's a really, really important place to start. While tennis elbow and golfer's elbow are generally clinical diagnoses, meaning we can be pretty sure what your diagnosis is without imaging, things like MRI and ultrasound can be really, really useful to show us truly what your diagnosis is. So in these MRI images, you can see this would be the lateral epicondylitis, so those extensor tendons. The tendon is thickened and it just looks abnormal. Then on this other one, this other picture, all that bright white, that's what we call increased signal, which is a fancy radiology way of saying you have inflammation and irritation in that tendon, where we would expect it to be a nice solid black line, not as broad as this one, but a nice solid black line. That white tells you that there's some sort of swelling, edema, something's not normal about that tendon. And that's what we look at and we can say, okay, based on MRI, you have the diagnosis we kind of thought, which was either golfer's elbow or tennis elbow. So we have sort of a tiered approach to treating both of these conditions. And this is sort of a good treatment algorithm for pretty much any condition that we see you for in the office. So the three different tiers are conservative, advanced, and then surgical. And so we'll kind of go through what those look like. So conservative, fortunately, most of the time, and I mean really most of the time, both of these conditions can be treated conservatively. What I will say, and this is one of the more annoying diagnoses, both for me as a provider and for you as a patient, this can linger for a really long time, but they usually go away and it's usually self-limited. And these conservative measures usually do a really great job to help with your symptoms. But if somebody tells you have golfer or tennis elbow, just bear with us because we know you're hurting. We know it can be really frustrating, but these conservative things do a really good job. So important place to start would be rest. If you can modify the activities that you're doing that exacerbate the symptoms, sometimes that's not the reality. If it's your job and you need to go to work, it's really hard to stop those. But if you're able to, that can really be helpful. Things like ice, bracing, the counterforce braces like they have in this picture right there, causing that compression over the forearm can be really helpful and alleviate some of the pain that you have. Then we do medications. Like a nice simple way to start would be anti-inflammatory medications like ibuprofen, diclofenac, meloxicam, Mobic. You hear all these names. They all function pretty similarly. The idea, again, you have this inflammation of your tendons. If we can calm those down with these anti-inflammatories, hopefully you get some relief. And then physical therapy. So stretching, strengthening, these exercises that are catered to your specific injury. And what's really nice is, frankly, these activity modifications and all these different techniques, they work for both golfer's elbow and tennis elbow. then our sort of more advanced treatment options. So these conservative measures, they haven't worked. Your elbow's still killing you. So what do we do next? What's our next tool? Those would be injections. Those usually are our next step after the conservative measures haven't provided you the relief that we're looking for. So we have sort of two that we like to lean on for tennis elbow and golfer's elbow. Those would be cortisone injections. What those do, the steroid injections you may hear people say, those can help to reduce inflammation in these really sort of severe cases that are not getting better with the conservative measures. So cortisone, the steroid, it can just overall help to reduce inflammation. That's what steroids are really good for. A lot of people will get steroids for other reasons in their knees, hips, shoulder, you name it. It's a really good tool to reduce inflammation. Then another injection that we often use is what's called PRP or platelet-rich plasma. So what we do in that case is we actually take your own blood, we spin it down in a centrifuge, and we are able to take the healing products from your blood and inject it directly into those tendons. And what that can do is kind of help promote the healing response in those irritated tendons and kind of calm things down. And that's another really great tool for us. And then we reach surgical. So you've tried the conservative measures, you've tried these advanced treatments with injection, and you still aren't getting relief after 6 months, 12 months. What do we do? So for tennis elbow, which again, if you remember, the extensors on the lateral side, what we do is we can either sort of what we call debride or clean up the extensor tendons right where they insert there on the lateral epicondyle. We can also tack those back down. So we can use, they kind of look like drywall anchors, frankly, to put the tendon back to the bone and hold that in place, and we can repair those tendons. Then on the flip side, for golfer's elbow, the flexors that insert on the medial, the inside of your elbow, frankly, what we do is we often go in there and just sort of release the tendons from their insertion on the medial epicondyle. Generally, there's not a need to repair it back down. People do really great. They don't lose the flexion strength of their wrist or their forearm. And just by releasing the tendons, you get rid of that irritant and you feel better. So that's a great option, but we of course like to try these other techniques first. So best case scenario, we prevent these from happening. So we do have some tools in our toolbox to help you out if you come in, you have tennis or golfer's elbow. But what can you do in your day-to-day activities to hopefully prevent a visit to us? Warming up, proper warm up, stretching before activities. It's a tale as old as time. Everybody hears it from the time they're a little kid. You got to warm up and stretch before you do some sort of activity. Like I said before, your equipment, if you're not using the right equipment, that can be really detrimental. That can change your form. And again, that goes to the next one, technique. If you don't have the proper technique, you may be stressing your muscles, tendons, ligaments in an inappropriate way. And if you just focus on the technique, may help. Strengthening, if you can do some regular forearm strengthening exercises, that really helps support tendon health. And so even little things with a couple pound weights, working on flexion and extension of your wrist, that can help those tendons and support their health. And then ergonomics, which is much easier said than done, but if we can maintain good posture, ergonomics in your daily activities, how you're sitting at work, a lot of us are cooped at a desk every day, but if you can keep good posture, keep the ergonomics, that can be really helpful as well. And then lifestyle modifications, these workstation setups or adjustments I was mentioning, if you can use some sort of tool to sort of reduce the strain during repetitive tasks, or maybe you need to take breaks throughout the day, that can be really, really helpful so that you're not frequently all day, every day doing the same repetitive tasks and just stressing those tendons. Alternative activities to prevent overuse. Maybe you really like golf and you're getting that golfer's elbow. Maybe there's another sport that you like too, and you can alternate so that you're not stressing those flexors quite as often. And then just like for pretty much anything, if you can have a nice balanced diet, rich in anti-inflammatories, and there's that picture kind of shows some really good anti-inflammatory foods, that can help just overall decrease that inflammation and make your tendons a little bit happier. So we've had a really sort of whirlwind overview of tennis elbow, golfer's elbow. Hopefully we got a little bit of a good understanding of what those two conditions are. And really, like I said, they're sort of a mirror image of each other. lateral epicondylitis, tennis elbow on the outside of the elbow, medial epicondylitis, the flexors on the inside of the elbow. And the treatment algorithm is pretty similar for both of them. My job looks a little bit different if we get to the surgery standpoint in terms of what I'm doing, but overall, the treatment algorithm or the pathway we take is sort of similar. So, some of our major takeaways early and accurate diagnosis is really important to help us manage both tennis and golfer's elbow. There's a lot of treatment options available. And fortunately, there's a wide range of conservative treatment options. So, it's really helpful if we can do those adjuncts. And then all the preventive measures we talked about, those can really be helpful to prevent either the first onset or if you have it once, we get through it together. Hopefully, it doesn't come back if we can do some of these preventive measures. So that's something that's really important to think about too. And I think that's it. That's all I have for everybody. I don't know if there's an ability to chime in and ask any questions if there are any, but I'm happy to answer any questions. I'll try and stop sharing my screen now so I can go back to, there we go.
If people would like to put them in the chat, that would be a good way that we could share those questions.
Yeah, perfect. Feel free to ask away. Happy to answer anything related to these topics or something else. If you got something else on your mind, happy to help. Let's see where the chat is. Okay.
I think that MH has raised her hand. I'm going to go ahead and let her.
Yeah, absolutely.
Let her ask you a question. Oh, I can.
We got a few raised hands.
We
I
have
think.
some raised hands. Trying
It
to.
looks like I can allow people to
You
talk.
can allow them to talk. Perfect. Okay.
Yeah.
I do not have that option.
All right. MH, looks like you have the floor. You may still be muted if you're trying to ask us a question. Sorry about that. Okay. Well, I will hold off. We'll go to the next question if that's okay. Looks like Kathy, are you able to chime in?
Can you hear me?
Yes.
Oh, cool. Awesome. Yay. Yay for technology.
Yeah.
Is either tennis or golfer's elbow, if there's pain, does that mean that the tendon is partially torn or not always?
That's a great question. Not necessarily. So, really the epicondylitis, all it means is inflammation, irritation. So you can have golfer's elbow and tennis elbow just by having inflammation or irritation of the tendons. Sometimes you get those micro tears or a little bit bigger tears, frankly. And those are what we usually can see on MRI, ultrasound, but you can have golfer's elbow and tennis elbow definitely without having any true tears.
So I have a partially torn lateral epicondylitis tendon. And yeah, the only way I've been able to completely get rid of the pain is to stop the activity.
Okay. Have you tried any of the other adjuncts? Like, have you done physical therapy, icing, any bracing?
I've done all the things. I hate wearing the brace.
That's fair. That's fair.
So
They're not exactly super stylish and they can be uncomfortable for sure. Um, But if it's something that's been bothering you for a prolonged period of time, it may be worthwhile seeing somebody about it and seeing if maybe one of these the next step, the injections, the steroid or PRP, those might be something that could provide you some good relief.
Well, I've done the injections. Like I've had 3 over the last 6 years. And
Okay.
my doctor basically says, if I can't, if I can't do something to get the pain to stop, the next step is surgery. I think that's where we're at.
Gotcha. How long did they help you for the injections?
Well, it's been a variety. So sometimes like a year or so, but my doctor and I both decided that I can't have another one. Like I've
Huh.
already had,
Yeah. Yeah,
so
it's not ideal to get them over and over and over again.
yeah,
Best case scenario, you get an injection or two and it calms things down enough. But sometimes the injections, the conservative stuff, they just frankly don't help. And so if we have to take the step to surgery, we make that leap. It's not a major surgery. It's generally an outpatient surgery in and out same day. Um, and it can provide a lot of relief. Granted, there's loads of inherent risk with surgery. Um, this is generally a pretty straightforward procedure, but taking that leap shouldn't be taken lightly just because there are certainly risks with surgery. This is a tried and true with predictable outcomes, but it can definitely provide relief.
yeah. Well, so if one has surgery, you have to immobilize the elbow for a certain amount of time after the surgery.
Usually we'll do just a short bit of immobilization, but that's more so just to sort of rest the soft tissue. If we do a debridement where you just sort of clean things up, usually you don't have to immobilize quite as long. If you do a true repair, we want to give that tendon that we've repaired back down adequate time to heal to the bone. So it may take a little bit longer and a little bit more immobilization than if you just do a debridement. But frankly, it's usually a call in the operating room. What's the quality of the tendon look like? MRI gives you a lot of good information, but nothing beats looking at it in the operating room. What's the quality of the tendon? Can we repair this? Should we just kind of clean things up? Like I said, that what is done in the OR can kind of dictate how long you're immobilized.
All right, that makes sense. Cool. Thank you so much.
Yeah, absolutely. Thanks for coming by. All right. Carolyn, looks like I think I gave you permission.
Yes, you did. Hi.
All right. Hey,
If you could demonstrate on your own elbow, the medial and the lateral epicondyle.
yeah, absolutely. Sorry, I
How
have a long sleeve shirt on. I
straight it
unbuttoned it real quick. So here's my hand.
Mhm.
Inside, this is the medial. So this is the inside of my arm. This is medial epicondyle.
Okay.
And then on the outside, this would be the lateral epicondyle.
So I'm pretty sure I have golfer's elbow. And I have
Okay.
no idea how I got it because I'm not a golfer. Um, I
Yeah,
do throw stuff, especially in the gym. I throw those weighted balls. I'm wondering
yeah,
if that could be the cause of this.
that certainly could be. And the terms golfer and tennis elbow, they're kind of funny misnomers because there's a lot of people that don't play golf or don't play tennis that end up with golfers and tennis elbows. So a lot of people are like, what the heck? I don't even play golf. How? But like you said, things like throwing, that's a very common one, especially weighted throwing. That can really put a lot of strain on those flexors right where they insert on your medial epicondyle. And so if it's something that you want to be seen, for sure, we'd be happy to take a look at you. But those conservative things are a nice place to start, and some activity modification is a good idea too.
Okay, thank you.
Yeah, absolutely. Thank you.
Okay,
All
and
right.
we do have some questions in the Q&A.
Oh, okay.
So MH has said, I've had medial epicondylitis for about 11 months, unable to swim hard, do curls or pull-ups, have no conservative and have done conservative and advanced treatments with no relief. Is there any hope?
Oh, come on. There's always hope. There's always hope. We always have more tools in our toolbox to try and get you some relief. Like I said, this is a really cumbersome diagnosis. I hate telling people they have tendonitis, epicondylitis, any itis, because it's just inflammation is really hard to manage and it can be really, really painful and it can drag out. You've tried the right things. You've tried the activity modification. You've tried the injections. It may be worthwhile talking to your provider about doing something a little bit more aggressive, whether that's surgery or otherwise. But it's not something that should be taken lightly when you take that leap from non-operative to operative. It's certainly something that you want to have a thorough discussion with your surgeon first. But there's definitely hope. Definitely hope.
Okay, and then Chris says, I think I need to come in and have you look at my elbows. I have a lot of pain when doing push-ups or weights, and this has really affected my ability to stay active.
Okay, yeah, come on down. I see patients at the Boulder office and at the Broomfield office. So happy to see you. We can definitely take a look at you, get some x-rays, like we said. It's always a great place to start. And then we can go from there and kind of see if we can work our way from these conservative to injections to the surgical if needed.
Now I have a question for you. So
Okay.
you mentioned that you do orthobiologics. So
Yeah.
is there a way that orthobiologics can help your elbow?
Yeah, absolutely. So orthobiologics is a really broad term. And so encompassed in that is a lot of different things. The one that really helps, I think, with tennis and golfer's elbow would be the platelet-rich plasma. And I sort of consider that under the umbrella of the orthobiologics. So again, in that case, what you do is you take your own blood, somebody will draw your blood, we spin it down into a centrifuge, and we take a particular type of or a particular part of that centrifuged blood, and we are able to inject it right in either your medial or your lateral epicondyle. What that does is your blood has a lot of naturally occurring items that promote healing. And so by injecting that in the tendon, it can promote a healing response and get those medial or lateral tendons to kind of calm down and promote healing so that we don't have to do something a little bit more aggressive.
Great, thank you. I think Kathy might have one more question, but that is the end of our questions.
Okay.
And MH also.
Let me go back so I can unmute. Okay. I think, Kathy, you should be able to talk.
Yeah, can you hear me?
Yeah, absolutely. There we go.
So I think I forgot to lower my hand, but it turns out I do have more questions.
Oh, perfect.
So does the PRP, if it's, so if the tendon is torn, does the PRP actually help repair and put the tendon back together or
So
not really?
that's a loaded question, and I'll do my best to answer it frankly. So if you have a complete tear, every aspect of the flexor or extensor is torn off the bone, the likelihood of PRP helping to completely heal that is pretty low. Now, if you have a partial tear and a majority of the tendon still on there, it can help to sort of consolidate and get that torn part to heal. It's also really good for what we call intrasubstance tears. So what that means is maybe the tendon where it inserts on the bone is still attached, but within the tendon itself, there's some tearing or fraying. PRP can be really helpful for that as well. It can kind of promote healing of that. But if you have a complete rupture, probably PRP wouldn't be able to help you much.
So it's a moderate partial tear, not complete.
I'm sorry, say that again?
The moderate partial tear, it's not a complete tear.
Gotcha. Yeah, I think PRP would be a reasonable option for that.
Okay. Cool. Well, I may just come in and see you as a second opinion.
Okay, come on down. Like I said, I'm at the Boulder and Broomfield offices. Happy to see you.
Great. Thanks.
Yeah, sure thing. All right. John, you have a question.
Hi, doctor. Can you hear me?
Yes, sir. Absolutely.
Okay. Briefly, in the past year, I had been diagnosed with golfer's and tennis elbow
Oh, gosh.
sports activities. I have received physical therapy, including
Okay.
scraping for golfer's elbow, if you know what that is,
Yep.
term. And for tennis elbow, it's been daily stretches, mostly some massages and NSAIDs.
Okay.
Also, when I play tennis, which is really hard to stop doing, I
Fair.
an elbow brace, which helps psychologically, if nothing else.
Right.
And I've also worn straps on my forearm, which it's okay. I don't know if it really works, but it helps. But I guess what my question really is, the physical therapies, the massages, the scrapings, all of that, and the braces and the NSAIDs definitely have helped relief. But obviously, you can't diagnose this, but the discomfort and pain is still there. It's just a case of, okay, I'm going to tolerate this for 2 hours, take Advil, ice it up, and do my stretches. And that's
Yeah.
kind of the routine. And then, oh, tennis tomorrow? Why not? So I'm guessing you've seen patients with a similar routine. So my question really is that really the outcome I should just expect to sort of have this? I've got relief, but it's not like the good old days. I'm 70
Yeah.
years old, by the way. So,
Hey, well, props to you for keeping up being so active. That's incredible. That's really great. You said it's been bothering you for about a year or so?
um, yeah, it's I don't want to get into this long story for everyone else, but yes, I would say a year
Okay.
is probably more or less. I mean, I first discovered my golfer's elbow playing tennis after I had done some weightlifting, which I believe was the root cause of
Gotcha.
the tendon irritation, stress, inflammation, or whatever.
Gotcha.
And physical therapy was brilliant. It really worked. But
Yeah.
tennis elbow never really wants to go away.
Yeah. Well, the challenge with both of these diagnoses is very often they're diagnosed in active people who want to keep being active, and their injury happens because they're active, and the re-irritation and the persistent symptoms happen because they want to keep being active. And that's just kind of the way it goes, you know. If you have tennis elbow and you want to keep playing tennis, that's I got no problem with it. Usually once the deed is done, once you have that inflammation, you may make it a little worse. But frankly, if you're able to grin and bear it, you're not going to make a profound difference in your long-term outcome. It may just be uncomfortable, you know, and like you kind of have to weigh what's it worth to you to be able to keep playing tennis. If you want to keep being active and it really bothers you, but you can get a little bit of relief with these things, I got no problem with that. I don't like telling people to not be active. So if it's something that is really killing you and you just can't move your arm, move your wrist, then we probably need to shut you down for a little bit. But I'm not going to tell somebody that they can't go do the things they like to do. We all really like to do things. I want to encourage you to go out and do those. So it may be that this is sort of the cycle that you're on, and you start to feel a little bit better, and you do something, and then you start to hurt and take a step back. But that's just kind of the reality of these epicondylitis is that the tendons are irritated. And so if you don't give them the opportunity to completely resolve, then it's probably just going to kind of linger.
Right. I shut myself down for another injury, not anything to do with tennis for 3 months, but my body says, I'm still here. When you come back to play tennis, I'll remind you, you know?
Yeah. Yep.
So, I mean, in other words, it's not acute pain, but but I know it's waiting.
Yeah. And like I said, this is one of the more frustrating things for me to talk to a patient about and tell them this is what I think you have going on. Because there's not a real satisfying outcome. You know, it's like, hey, sit around for a while and you might start to feel a little better, but also it might bother you for quite a while. So
Mhm.
kind of a challenge for that discussion to get patients on board with like, hey, this guy actually knows what he's talking about, or like this guy is just he told me I heard, I already knew I heard, and he doesn't know what he's talking about.
Oh, I'm not accusing anyone of that. I'm
Oh,
just
no, no, no. I know. I mean, it's just a frustrating diagnosis because
Mhm.
it hurts and it keeps hurting and it can just linger.
Yeah, I think the prognosis is just deal with it if you can.
Yeah. Unfortunately, that's sometimes what we got to settle for.
Mhm. Right. Well, thank you for your input.
Yes, sir. Absolutely. And MH, did you have a question?
Can you hear me?
Yes, absolutely.
Oh, great. I finally got it fixed. Okay.
All right, perfect.
My question is, I would, their situation is very similar to the previous question. That is, I've been kind of out of commission for doing hard swim workouts and many weight activities for close to a year now. And I've done the conservative treatment, done the things that you called advanced treatment, and still really no real concrete change. I mean, it just, and I'm
Yeah.
just wondering, is there any hope?
Yeah, yeah. Definitely there's hope. There's always different things we can try. It may be that you need to have a discussion with your provider. Hey, we've tried, we've failed. And I don't like to use the word failed because it makes you feel like somebody did something wrong. But we've tried these different things. We haven't had the outcome we've wanted. Maybe we need to talk about getting a little bit more aggressive and talk about surgical intervention.
Now, so I've read some papers that sort of suggest that surgical intervention doesn't have a super high success rate. Is that, would you concur with that, or is that, or am I misreading things?
No, I mean, you can find research that says anything, right?
Well, I'm not. I'm trying to selectively pick
Yeah,
qualified
yeah,
research. That is
of course. No, no, no,
peer-reviewed
of course,
type
of
stuff.
course, of course. But even qualified researchers, they're really good at making things say what they want to say or not. But all that aside, my experience is one, these conservative measures often do help. Most cases can be treated with that. That's not the case for you. Then like we said, we take the next step. These don't work. Then we got to talk about surgery. From my own anecdotal times, I've had really good success with both golfers and tennis elbow being treated surgically.
Uh,
Again, there's inherent risk with surgery. You invite the opportunity for a new type of pain because
yeah.
you've had an incision, you've had surgery. So maybe the tendons heal really great, but you have sort of residual pain from your incision. You know what? So that's why I emphasize that surgery can't be taken lightly. There's a lot of inherent risk. My experience is that people generally do pretty well, but that may not be every provider's experience.
Yeah. Okay. All right. Thank you.
Yeah, sure thing.
Chris has asked, I think it's very similar possibly to the last question, but for tennis elbow, how effective is the debridement procedure?
Yeah, it can be really effective. Again, you kind of have to take a glance at the tendon while you're in the operating room and you say, hey, what's the quality of this tendon? If we repair it, will it stay repaired? Is it something that will heal? Or is it something that we just need to kind of debride and clean up? And like I was just saying, I have seen a lot of success with this. Again, this is sort of the last stop for the train. You know, we have to not have success with all these other things before we go to surgery. And in my experience, people generally do pretty well.
Right, and then we have one more question. Can you get tennis elbow from motions generated while playing golf?
Yeah, yeah, absolutely. Like I said, golfers and tennis elbow sort of they're misnomers because you can get one from the other, you can get it from other activities, but frankly, in golf you do have a backswing, and on your backswing you're engaging your extensors, and that would be the lateral epicondylitis. So certainly there's positions in golf. It could be other daily activities that bother you, but you can definitely get one from the other.
Perfect, thank you. I think that is the last of our questions, so thank you so much.
Yeah, absolutely. I see a hand raised.
That is Chris. Oh, I mean, he
Chris,
might be able to unmute.
you have a question, Chris?
Yes, can you hear me okay?
Yes, sir.
About the debridement procedure, it doesn't seem too invasive. I am wondering about the type of anesthesia you would use in a procedure like that. What are the options? Is it always a general, or you can do some sort of a local thing? Or
So two things to say about that. Some people will do debridement arthroscopically, meaning they do couple little poke holes and they look at the
Right.
tendon with via arthroscopy with a little camera. My experience is I like to do it open. It's still not a big incision, but I like to sort of directly visualize it as opposed to doing it with arthroscopy. I find it's a little bit more intuitive, a little bit easier for me. I just like it doing it that way. But generally, I like to use general anesthesia. It's just it's quick. We don't usually do a full intubation where they put the tube down your throat. Generally, now they'll use what's called a laryngeal mask airway or an LMA. It's just a mask that sort of sits at the back of the throat.
Great.
But usually, I like to do general anesthesia. There are some providers that will do a local block or they'll do other sort of like local anesthetic. I find it better if everybody's more comfortable, you're asleep. They don't use a ton of anesthetic for it to put you under. And like I said, there's no tube down your throat. But my experience, people do a little bit better if they're asleep. But again, there are providers that will do it with you sort of more of a local or a block of the extremity.
Okay. Yeah, I had hip surgery at the end of May, this last May,
Okay.
and absolutely amazed at the recovery.
That's awesome. That's
Yeah,
great.
I mean, I was talking to Dr. Chen about it. I was just like, I am just astounded.
He's awesome, isn't he?
Yeah, I used to scrub in surgery back in the late 70s.
Oh, very
And
cool.
one of the things I was, smaller orthopedic stuff, but one of the things I had to do was hold up the person's leg during the hip replacement. So I got a
Yeah,
nice visual of all that. So I was going in with all of that into this surgery. And I am just amazed at the low impact that it had on my life, that whole thing.
yeah, that's
So very,
fantastic.
very impressed. And it was a spinal. They did a local tap,
Yeah, spinal do really well for hip procedures.
which was kind of amazing because it appeared that it affected the hip side, but not my right side so much as far as the numbness goes. It was really amazing
That's
coming out
awesome.
of it. But anyway, so I was looking for kind of the same thing with the elbow because I I got to get these fixed. I got to get these looked at. I can't lift weights. I can't do the carpentry work that I need to do to get projects done around here. So I think I
Yeah,
need to come in and have you guys take a look at it. But I'm not afraid of surgery.
yeah. Well,
So
come on down. Like I said, I
awesome.
see patients at Boulder and the Broomfield office, so happy to take a look at you.
Excellent, Dr. Schreier. Thank you so much for coming out tonight and giving us this
Absolutely. Thanks
lecture.
for tuning in. All right.
Yes,
Sally, did we
thank-
get all the questions?
I
don't see your
believe
hands.
so. There aren't any more. So we have recorded this, and so we will also send it out to everybody. So if you did missed any of it, you'll have that, and also send it to anybody who signed up for it. So thank you so much.
Awesome. Yeah. Thank you for setting it up, Sally. Appreciate your help. Thank you everybody again for coming. Happy to see anybody for this or any other condition if you need a hand. Like I said, come see me. If I can't help you, I'll point you in the right direction. We have so many providers for pretty much any orthopedic subspecialty or a body part that's hurting you. So if I can't help you, I know somebody in the office that can. So feel free to stop by. Anything else you need from me, Sally?
That is all. Thank you so much. Have a great night.
Yeah, no problem. Take care. Thank you.